Hi, everybody. Thank you for joining us on Opilio's Optimizing Healthcare Revenue webinar. Joining me today is David Buck, CFO of Taylor Counseling Group. Dr. Taylor should be joining hopefully pretty soon. He had a little bit of an emergency meeting come up, so whenever he is available to make it, I'll stop and introduce him more formally as well. But thank you guys so much for coming on. I want to go ahead and introduce our panelist who we have right now, which is David Buck. He's the CFO of Taylor Counseling Group. David is also a licensed provider as well. And one of the great things about Taylor Counseling Group that I really loved as I got to know them better and work with them is their entire corporate team, even of course, including Dr. Taylor. They are, executives and business leaders, but they're also clinicians and providers as well. So I think that's something that is at least somewhat unique and really, helpful not only from a practice of medicine, but also helpful from a, kind of a vendor consultant relationship is David and your team, you guys see things from both the business and the care perspective. And not all leadership teams have that ability. So thank you for being on today. Why don't you kind of introduce yourself a little bit as well?
Absolutely. That's a pleasure. When you're talking about it, creates a nice synergy and balance, right, to doing business because you always have to have people in charge of making sure the lights stay on. Obviously, as CFO, that's my role, the general financial management strategy of the company. But even more than that, a big focus of what I do is ensuring that our billing strategies not only maintain up to date policies, codes, laws, regulations, but always looking how do we take that next step, keep abreast on everything that is changing all the time. Providers really don't realize, I think, a lot of times how quickly they do change, but then maybe even finding strategies to, especially for us in the mental health space, be at least one step ahead, if not more. So that's kind of what I focus on with the practice is how do we keep effective billing strategies, not just for, of course, our ability as a company, but for our care to our clients. A big part of our mission and our goal is affordability and accessibility in mental health care. And those are huge barriers, unfortunately, for just about, I would say, most states out there. So I am focused on making sure that those barriers are torn down as quickly and efficiently as possible, and we keep them that way.
So I want to introduce Dr. Taylor now. So Dr. Taylor is the CEO, founder of Taylor Counseling Group. Also, uh, part of TCG's mission, Dr. Taylor, we were just talking about, was accessibility and affordability, as well as the fact that your your executive team is somewhat unique in the sense that the leaders are also not just business leaders, but also providers and practitioners as well. And that's helpful, to people like me because we're able to kind of balance out the business side and the care aspect of the business. Um, why don't you take a moment and kind of just more formally introduce yourself so that people get to know you?
Sure, absolutely. So my name is Dr. Christopher Taylor. I founded Taylor Counseling Group in 2015. We built it on these three pillars, this idea of in order for mental health, in order for outpatient therapy to be effective and successful, we believe that it has to be affordable, reliable, and accessible. And so with that, we have from the very beginning taken an employee first mindset, making sure employees are taken care of, that all of their needs are met before we go on to providing exceptional client care. We do this by offering our therapists highly competitive fixed salaries that are guaranteed every week, so they don't get paid per session or completed. We also accept every major insurance that's possible, and we'll be rolling out Medicare here very soon. And we also do this by providing some telehealth options, and we do this specifically by servicing the state of Texas, which ranks last in access to mental health care.
So, one of the things is how much work you do in the community. And where I kind of want to focus is affordability and accessibility. And that's part of really Opilio's mission, is to make care more affordable for the patient, the end user, and accessible, with the theory being that if providers are reimbursed, you know, amounts that lead to sustainable profits, you know, not asking for things out of this world, but sustainable profitability, we're going to gain more accessibility. And over time, because more patients are able to come get good quality care, it'll also become more affordable as we lower the cost of healthcare. Uh, do you have any kind of thoughts on kind of the macro perspective there on how affordability and accessibility also relate to, you know, reimbursement rates?
Yeah, I do. It's a great question, Sean. And part of my dissertation and my doctorate was working with Dallas County's Family Drug Court program to apply social learning theory to drug courts. So what we found is that human capital is this principle of investing in people and in their environment created big change. And so one of the things that we saw out of that study was a very significant reduce in recidivism rates, meaning that moms that came out of these drug court programs did not go back into treatment, whereas ones that didn't or were adjudicated, they went through, they were back in treatment. They were back in treatment, which means that they're back in a psych hospital because they don't have private health care, which means that they're sitting in waiting rooms and emergency rooms, which are the most expensive way to treat a problem. I mean, just like with diabetes, the worst thing you could do is wait till you're in diabetic ketoacidosis and end up in an ER. You know, that's a very, very expensive way to deal with diabetes, rather than just doing what you should be doing, taking a little bit of insulin every day, monitoring your progress over time, and then having a relationship with a medical doctor and a nurse practitioner to kind of help you with that course of treatment over time, monitoring your food intake. This is the same model that we're adopting. We're just applying it to mental health. We believe that if you invest deeply into outpatient mental health, we will reduce the strain and burden on our psychiatric facilities, on our inpatient facilities, which are a much more expensive way to treat the same problem. If we could help people to not get to the point to where they're suicidal, instead of just working with them while they're depressed, giving them access to healthcare, giving them access to outpatient mental health that's reliable, that's affordable, they can afford to do every week, then we believe, and we believe we have evidence to show this, that they will, over time, those massive recidivism rates will drop, and we'll see people stopping to go back into the hospital over and over again. I was just at a Grant Halliburton event last week, and the speakers were Kevin and Kevin, and Kevin, one was a retired police officer that works on the Golden Gate Bridge in San Francisco to stop suicides. It's had over like 600 people have attempted suicide on that bridge. And the other guy was Kevin, who was a guy that this retired police officer helped to get off the bridge. Well, in the talk, he talked about that he attempted suicide 22 times, 22 times, you know, because he had a stigma, he had shame, and he didn't have access to mental health care. And so each time he ended up in an ER or in a facility, you know, and we see this with drug addiction and alcohol addiction. The joke at AA is like the 13th step is that we're going to go back to the hospital, you know, like, yeah, you're going to get clean and sober for a year or two, but then you're going to relapse and you're going to go back, 2, 3, 4, a dozen times. And we know that leaving inpatient care means that they typically don't continue with outpatient care because they just spent an obscene amount of money, 30 grand, 300 grand on treatment for 30 days. Now they don't have the money to pay, $150 an hour for therapy. But what if they did? What if it was $20 a session? What if it was covered 100% by your health insurance? And so that's the approach that we take.
And, when you think about the numbers, because there's a lot of statistics and math to kind of back up this theory that if people take proactive care of their mental health, the odds of having a catastrophic event do go down. In the current state of reimbursements, what we've seen is the insurance companies model their reimbursement rates from a fee for service perspective, really based on what CMS and Medicare are paying. And when you look at the trends in just the CMS rates, they've been at really either stagnant or declines over the past 26 years, especially in regarding mental health. Each specialty is a little bit different, but when we looked at kind of this data, what we're seeing are reimbursement rates that make it very, very difficult to lead and have success, especially in mental health, especially with a practice of your size. One of the
Yes.
things that the data has kind of shown me in my work is economies of scale are really punished in healthcare. And what I mean by that is, as a practice gets bigger, it will naturally see more volume. And so the insurance carriers, when they analyze, they kind of build a fee schedule that is built around a patient in, patient out model. Whereas, solo practitioners are getting, which isn't bad, but the solo practitioners are getting more premium rates than a larger organization. And without bringing judgment on, a bigger group versus, a solo practitioner in private practice, what I really mean to say is the cost of a patient's care doesn't really scale, right? Like people in healthcare, people are not iPhones, for example. So if you produce 100,000 iPhones versus 1 million iPhones, your cost structure is going to look much different because you can divide your overhead across a larger base of patients. Whereas in healthcare, you have way more variable costs tied to the actual patient than you really have, like, from an overhead perspective to
Right.
just divide over the number of lives. And I think that is a nuance that many people really don't think about. I think one of the things that makes me unique is having a kind of a CPA accounting mindset and kind of looking at the nuances of the industry and saying, well, hey, like, this is one reason why it doesn't, based on these reimbursement rates, it doesn't scale appropriately the way an insurance company may want it to. And, from that perspective, I guess, I want to be careful. And, the insurance companies at the end of the day are really partners. We have to look at them like that, not villains. It shouldn't be, a confrontational or adversarial battle. It should really be more of a partnership. But, when you're trying to build sustainable profits and come to a place of more of a partnership view, can you talk a little bit about kind of some of the obstacles and difficulties that make that a more difficult process than maybe it should be?
Right. It's a great question. One of the many things we struggle with is, larger hospital facilities, let's say like Baylor Scott and White or UT Southwestern. Right? I mean, they have entire departments of teams that process claims. They have entire departments of teams that negotiate and credential. They have counterpoints at the insurance companies to have ongoing conversations with. And, we're talking about outpatient mental health, especially for master level clinicians, which is the majority of the workforce. If I want to just go out and start my own practice tomorrow, I mean, I have no relationship with Blue, Aetna, Cigna, United. Like, I have to dig and dig and dig and find countless hours of my own time to find a phone number to call so that that person can call me back in a couple of weeks, if at all. And I'm not trying to throw them under the bus at all. I think you're totally right, Sean. They are partners and we want to work with them. We want to take the insurance. It's very, very difficult to be a clinician to work with 30 patients a week. And I remember doing this when we first started out. Like, I mean, when I was just the only therapist at Taylor Counseling Group, when I was the only counselor at Taylor Counseling Group, I would, in between patients, sit on hold to try to figure out where this claim went or why this claim was denied or which. And I didn't have that many patients, man. And it was still difficult for me to figure it out. Now, imagine doing that for 76 employees. Without the resources that these larger hospitals have, it's extremely difficult to manage that. We don't really have like a liaison program with them where they call in and check on us, or a number that we can call and say, hey, here are our needs. And you're right, people don't scale. People just don't scale. We can hire more people. We have some economies of scale, like the more people we can get into an office, great. The more efficient we can make the schedules, great. 5 people or 500 people, we still just need one website, so like those things will build scale over time, but it's not significant amount like your example of a product like the iPhone.
Yeah, and I think that's really one of the key problems that Opilio serves to function as, is kind of that day-to-day, call it project manager of the actual negotiations and the data analysis. That way, you can focus your time on serving your patients, and someone else is kind of handling the more administrative tasks and the more data analysis tasks. Because one thing that has proven very helpful, and I want to turn it to David because you and I worked really closely together on these projects, is when it comes to data and price transparency, it's relatively new. And I know you are in your role as CFO are kind of messing with the spreadsheets to keep it simple most often. What are your thoughts on just the data and the price transparency from a reimbursement perspective? How helpful was kind of having that data at the tip of your hands for you to kind of evaluate just where you stood?
It's very
before you
helpful.
answer that, can I just
Yeah.
Before you answer that, can I just say, Sean, I got to jump off here. I got to make
Sure.
it over to Frisco for another event.
No
I'm going to
problem.
leave you in the very capable hands of my CFO, who is much smarter than me and knows way more about this than anybody else, at least anybody that I know. So you guys have a great day. Thanks so much.
Thank you.
Thanks.
Yeah, the transparency of the data is extremely important because the reality is, for us to be able to partner with insurance companies, there has to be, like any good relationship, a level of transparency, a level of authenticity that you can't develop when you're forced to operate from this position where you don't really know what you're getting into. You don't actually have an understanding of what even standard fees are. As you mentioned at the start of this, a lot of it's based off CMS reimbursements. So you can generally have an idea of maybe where it's going to land. If you look at CMS rates, of course, they break it down by MAC, locality, region, state. It's very nuanced. Half the time, I don't even think they follow their own pricing models. No offense, don't come at me, CMS. But there's so much nuance and intricacy to it. And at the end of the day, without the actual payers themselves being a little bit more direct and authentic with us as providers, how are we supposed to know? Are we doing mutually beneficial work? Are we charging too much, not enough? Obviously, we want to make sure that cost is fair and, again, affordable, right? So that we don't create now a barrier to accessibility to our clientele. But at the same time, as a business, I mean, how many other examples of business can you think where you're basically doing a service and shaking hands and signing contracts with other parties where they basically tell you, but you can't know anything about the pricing. You can't know what the pricing is. I'm not going to tell you what this market over here is doing. It's kind of insane, and it makes it very impossible for you to make an educated decision on what best practice is, right? It also makes me not necessarily feel great about the partnership always. So when they did recently, add those new laws and updated them, as you were kind of alluding to, the price transparency, it's got a whole long fancy name, like all the laws do. I can't remember exactly what it is, but that was huge. Them being required to put those rates and post them officially on whatever their website, easy accessible. But even then, and that's one of the reasons why firms such as yours, Opilio's, is so important. I can tell you, as a provider, when I heard about it, I was super excited. I thought it was Christmas morning, and I'm running out to go get those rates, and they were packaged in these archaic JSON files. I don't even know how to properly say it because I never saw one before. So forgive me, I'm not as tech savvy as I'd like to be still. And it's impossible. It was just like I basically had all this hieroglyphic data, essentially, no Rosetta Stone. And I learned really quickly there maybe were ways for me to figure it out myself, but we're talking excessive time, excessive resources, way too many headaches that I don't really want to have. And the cost was still going to be fairly high. I was going to have to purchase certain things to even decrypt essentially these files so they made sense, other than the option I went with, which was, hiring a firm, such as yours, who has better access to that data, can provide me with direct answers to that transparency. You tell me, Sean, how much does Blue Cross pay my market? What's my competition look like? How can we actually start developing an idea of our real world metrics, so that when I do want to sit down with these guys and develop a real relationship with them based on trust, equal value, respect, and knowing that there's a fair, mutual investment in one another, I actually feel good about it. And that's where obviously you come into play.
Yeah. So, I think just for a little bit of background and history context there with the
Yeah.
data, you're right. They do post it in these archaic, um, I hesitate to say archaic because JSONs are still relatively,
Right.
normal, but in these large JSON files, it takes kind of specialized knowledge, specialized skill set to really make usable. And even from that point, just the bulk data downloads that we receive for your work, we're talking upwards of 8 million rows of total data.
Mhm.
Um,
A lot.
because, I have access to the data, um, but I do pay for that access. I'm not a uh, just price transparency firm,
Mhm.
because just the data alone, as helpful as it is, when you're talking 8 million, 10 million rows of data, it does take someone time,
Mhm.
and it's better to have someone with a specialized skill set to be able to analyze that data. And where I'm really trying to go is talking about actually like benchmarking to,
Absolutely.
apples to apples within the data set, right? Because one of the things that I
Mhm.
pride myself on is just integrity and transparency. And, just because there might be a provider out there who makes 40% more than your reimbursement rate, I'm to you and to all my clients, I tell, I try to give them an idea of what's realistic and achievable versus, what might be out there, because there's differences in taxonomy. But there's also just, you can be same CPT code, same taxonomy, same general area, same zip code, but as I was saying earlier, a small private practitioner solo practice is going to be reimbursed much differently than maybe a larger organization, and a larger organization is going to be reimbursed differently from perhaps like a public health company as well. So
Correct.
it's getting through that data and finding the five or six similar organizations to the client that actually provides a basis of strategic negotiations.
Mhm.
um, and one of the things that I really enjoyed about working with you guys, especially in the mental health field, is to have strategic negotiations. You need to be an effective communicator, but there's some psychology based in that as well. And so I tend to talk about what I do from there's the science part, which I think we've hit pretty hard on the data, the transparency, the reimbursement rates, and why. But then there's also kind of a strategic art component, which is forming a proposal, which I do for my clients, and just going in the day-to-day conversations just to get the network managers engaged to hear your request out.
Exactly.
Can you speak to the importance of it's not just a data analysis. There's a strategic component of communication to this process.
Oh, absolutely. And that's one of the reasons why, working with you, I appreciate that we collaborate very effectively together, because one of the benefits, as we kind of started off with this, TCG has been able to stay pretty nimble and pretty ahead of some things in our field of practice, because we aren't just focused on the business side. We are clinically trained. We are psychotherapists. We get the nuance of developing relationships and how to develop rapport and connections. And that's really what we're talking about. Again, if we're developing a relationship with these guys, it actually does include relationships with those individual network managers, higher up directors, whoever's in charge of the contracting and all that other fun stuff in the negotiations that you've spoken to a lot with recently. So even though step one really is, how do we even get a hold of them? How do we know who the right person is? Once you do finally get the right person, which is a very difficult task, unfortunately, sometimes in and of itself, what do you do with them? Because real world experience, and I used to do all of our negotiations, this is the first time I've ever brought anyone on board. So I understood the value of being able to reach out to network managers when it did work in theory, and develop those relationships and rapport. And the only time I had success on my own is when I was fortunate enough to, over a span of years, sit down or talk with somebody, whether email or phone, that I already knew. I had already spent years investing in this relationship. We had already become, first name basis, professional, of course, but it was much more friendlier than, if you go dial up someone at Blue Cross, you're just going to get some random person, right? So are you going to really do all of that work, especially if you're in private practice and you maybe are just the only clinician yourself? Like I was afforded, of course, the opportunity in my role. That's a big part of it. I get to focus a lot of my time and energy on my relationships and my connections, and building and finding and connecting and maintaining that. Most providers don't have that opportunity, because it is such a resource, such a time sink, really, when you would rather be with clients or hopefully clocked out, playing with your dog and your family. So being able to have just the time and resources, of course, is huge, but there's so much nuance to it, because you're going to hit a wide variety of network guys who, anywhere from no, won't talk to you, ignore you, here's your standard rate, have a nice day, all the way to, sure, you might find a diamond in the rough that says, oh, we love you and we absolutely see where you're coming from. Let's talk about getting you more money, right? That's a perfect world, but that's essentially like the metric of like, okay, great, money's growing on trees now at this point. It's not very likely you're going to find that person very easily. So how do you develop that relationship, and how do you provide something? What do you bring to the table to show them who you are? Because again, when talking relationships, if we're speed dating, which is a lot of what this feels like, I've got to find an effective, efficient way to sell you on who I am. What quality, what value am I bringing to the table? Why is this a good mutual fit? And that's a lot of what these negotiations are, is how do I do that in a short window of time to connect with them? And then now from that, what do we do with it? How do we really negotiate effective, terms, again, for all parties, making this a mutual benefit long-term, not just a short-term fix?
Yep. And, I think there's a key word that you said, which was collaborative. And the reason I bring up collaborative is because, each client's a little different. And the more collaborative the process is, the better I can understand your organizational goals, the better I can build those relationships for you. And some are easier than others. And sometimes it's just persistence and sending an email every single day, making a phone call every single day for, sometimes 2 weeks straight. But, typically, that's only happened once, but yeah, and it's also kind of understanding the other organizational goals where, each carrier is a little bit different. Each carrier has a little bit different strategy. Each carrier looks at the data a little bit different. And so kind of knowing what they expect in a proposal is another helpful way that, you can bring more value to the table in the process. So, in the context of time, I do want to say I'm going to drop for the people on Zoom, I'm going to drop my calendar link in the chat box. If you'd like to learn more about what I do, for me to share insights, please feel free to book a call on my calendar. I'm happy to walk you through the process and my own experiences to kind of help you get where your practice needs to be from a reimbursement rate perspective. I do want to say, if there's any questions for David or myself, there is a Q&A block inside of the Zoom webinar. If you want to just input your question there, we'll stay for a few minutes afterwards. But I think a good way to conclude this, and I want to give you the floor here, David, is it all takes kind of a team. And we talked about the economies of scale or lack thereof in healthcare, the difference between other industries. When we look at healthcare and the flow of sustainability between the different partners, it's going to take teamwork, collaboration. I'm going to bring it up again between the insurance carriers, the providers, but also, we as a society. I think ultimately we all know we have to lower the cost of healthcare, and that does, there's a component of that from of accountability on each and every single one of us. And as we kind of go forward and look big picture at some of the changing trends and what's upcoming with alternative payment models, now's the kind of time that if you're a leader or a practitioner, consultant, wherever your place in the industry is, now's kind of the time that we all need to start coming together and figuring this stuff out, or else I'm afraid it could get very ugly in what many people already consider to be a broken system. Do you have any kind of final thoughts just there from a more general perspective?
Well, absolutely. Yeah. So where we stand in a perfect world, we're supposed to be in a free market. We're supposed to be looking to insurances to manage our risk as individuals. These are supposed to be companies that are at least legally, for the most part, they're non-for-profits. And then we constantly have to look at them reporting their ever massively growing net profits on a quarterly annual basis, and then questioning, okay, but where's that money coming from? Who is it for? What are you spending it on? Like, that's not how this is supposed to work. And you hear a lot of the talk about, okay, especially even the mental health space, we know that there's not enough accessibility. Cool, great. What are you going to do about it? Oh, well, we know it's not affordable. Cool, great. What are you going to do about it? They like to say, oh, we know. And I'm like, that's nice that you know. I trust that you know. But what are we going to do about it? Again, as a mutual relationship, not just looking to them and saying, I trust you to fix it. Good luck. They won't, not without us as providers stepping in and trying to collaborate with them, trying to develop these relationships and let them know that, look, we understand from a very basic risk assessment model. And frankly, if it's not broke, don't fix it. The way you've been structuring things for decades at this point, you seem like you got a winning, winning recipe. You're going to keep pushing it. The problem is it really isn't. It's only a valid recipe, again, a strategy, if all parties are mutually taken care of. And the irony is they're predominantly supposed to be taking care of us. If this was a financial sector, we'd be talking about your fiduciary responsibilities to your, right? Like they have that to us on a medical standard. And I think that not maybe intentionally, but over time, because we live in a very capitalistic minded society, we've maybe lost sight of that. And that's why I love being in my position, even with TCG, is being clinically connected as well. I don't lose sight of what really matters most, which is you guys, the people. People is what matters most. What Dr. Taylor talked about, one of our core tenets is human capital. That is what is the real value. And they're using value as the word that they are absolutely starting to push now, value-based type care, and trying to sell it with these really cute little butt-in ways of saying, oh, it's going to do this and it's going to do that. It's going to create all this wonderful, accessibility and affordability for you guys. And it's going to save us a ton of money too. And then when we save money, everyone saves money. That sounds nice in theory, but we have numbers that even there's a lot of, these bodies in different markets that are trying similar things out. It's just not reflected. And it goes back to where we started all this with, if we aren't providing actual true value-based care across all different sectors and learning a healthy way to integrate that, then people will continue having, like you said, emergency events and other health, related concerns, mental health, physical, being very much tied together. Mm-hmm. And the costs are going to stay up. If you go with these other strategies, what they end up doing is they still act from a very service fee based way of modeling it. And they either are devaluing these services, which now makes it less likely for me as a provider to render them, or they structure in a way that even certain populations who it's supposed to be helping, it now creates an inverse relation to where I'm going to now be less, reimbursed. It's going to be more difficult for me to be reimbursed potentially the current trends that they're tracking CMS and what they want to push more value-based to help these clientele. So now if I'm in private practice, why would I want to invest in these populations? Because I know that statistically speaking, it's harder to keep them in therapy or in any type of treatment. It is far more likely that there's going to be the recidivism. It's far less likely, unfortunately, they're going to be able to afford their medications they need, all the other different treatments they require. And then when you look at me and say, well, you don't have the same levels of returns, you're not offering enough value, therefore I'm going to pay you less. Or, I'm going to now take that risk and I'm going to put it back on you, and you're going to now pay fees, essentially. You're going to pay us back, being doc, for this. It makes no sense. And maybe a company like ours, at least we would like to believe that we're, client, maybe not client first in our general structure, but client very high up there, like we would do the right thing, ethically speaking. But I'll speak very plainly, the majority of the professional population, it's not even going to be that they don't want to, it's going to be that they cannot do that. So the reality is we do need fair reimbursement as providers, so we can keep the lights on, so that we can provide the right services, and so that people really have options. Because we believe in a free market. There's no reason to change the actual model that we know works. And that, I think, is kind of where we're slipping up right now, is the market doesn't feel very free right now. And it certainly doesn't feel like it's always fair. And the first step in fixing that is transparency, relationships, building trust and mutual value.
Yep. And I'm glad you brought that up, because maybe that should be when we work out the LinkedIn Live glitch issue, that should really be a second conversation we can talk about on the value-based care. My biggest concern with value-based care is it shifts the risk from the insurance company to the provider, which makes me question what we would even need the insurance company for at that point
Right.
anyway. But
Exactly.
yes, there's a whole host of issues, and I think that would be an amazing
Yeah.
second session. So, David, I really appreciate you coming on today. Appreciate your time, and thank you to everyone who's still on. I still see some attendees on. Thank you for joining. And I think at the end of the day, if you're in a place where you can use help from a reimbursement perspective, please don't hesitate to reach out to me. Otherwise, keep a lookout. I'll be sending a recording of this to everyone who attended, and I will also hopefully be scheduling that second session because the value-based care stuff would be really neat to get into once I've worked out the LinkedIn Live. So thank you
Yeah.
guys so much.